Chapter 5 is all about DQ relationships. Okay. Ultimately, what you're trying to do is you're trying to get oxygen to transfer from the air to the tissues, okay, and that requires that you have to go through these steps of falls as you get from one compartment to the next. The first compartment that you see up here is up in the mouth. That's where the PaO2 inside the airway is 100 150. That's your first part of the equation of the alveolar gas equation, which is the water vapor pressure minus atmospheric pressure times the FiO2, which in this example would be 21%. So your value initially up here is 150, okay? And then the next thing you encounter is when you get down to the alveoli, the CO2 is coming out, which is 50, which is the PCO2 over R, which is 0.8. So it gives you this value of 50. So you're down to really an oxygen gradient of 100. So 100 would be a perfect situation. Your P little a O2, which is your arterial O2, would be exactly the same as your alveolar. Okay, that would be really a healthy individual. Somebody who's a runner, somebody who rides bikes all the time, who has really good diffusion capacity, basically almost equilibrates at the same concentration as their alveoli. Okay? Some people are very fortunate. Most of us are not. Most of us are a little bit overweight. Most of us have a little bit of extra thickness in our lungs, either from disease or from some other smoking or something like that. So as a consequence, usually you get a gradient as much as 4 to 5 millimeters difference. So the normal PaO2 is anywhere between 95 to 96, and that's considered normal. Okay, so that if you draw blood gas in that individual and they get 96, that person's A gradient is insignificant, nothing to worry about. Once you get more than that, if you get into a diffusion capacity problem, or you get into an issue where you don't ventilate the alveoli properly, then your gradient becomes greater in the sense that you're getting less PaO2 in there. So the uptake becomes a limitation in that situation. And eventually, your oxygen gets down to the tissue where then it uptakes and leaves the arterial, so it doesn't go to 0. You should not see venous O2 to be at 0. That's not a good sign. That means you've uptaken so much of the oxygen that you've basically got no reserve. And what happens when the blood returns at 0, what happens to saturation, the next cardiac output? It doesn't have enough time to get enough stuff into the plasma as well as into the hemoglobin, so saturation falls. Where would that be an example that you would see that actively in clinical? Give a unit of packed RBCs to somebody. You actually will see the saturation drop. How many have seen that in the ICU? Okay, the reason that the saturation drops when you give the hemoglobin that's at packed RBCs, it's been sitting on the shelf with no oxygen in it. So now the oxygen level in the actual bag has gone to 0. That's why when you look at a packed RBC bag, it looks really dark. It looks ugly. Versus if you were to oxygenate that nice blood that you're giving would turn bright red. Okay, if you were to give oxygen to it. Okay, I've seen it done one time. I just had one of my friends was a great experimenter. He always liked to play with stuff, and we always looked at stuff and he said, you know, John, this is not really like blood in our blood vessels. I'm going, why? He said, well, watch. And he would took a tubing and put an oxygen filter and then pumped oxygen into the packed RBC bag. And then all of a sudden the bag turned red, red, red. I was like, wow. So that's what happens when it hits your bloodstream. It's actually dark, dark, dark because it's all venous. And it's completely desaturated. And usually you'll see the sats fall between 98 to 96% when you're infusing, let's say, 1 unit of blood quickly, like in 10 minutes, it's gone into the blood vessel, which we can do in the operating room pretty often. That's something you don't necessarily see on the floor, but one of the things we can see is we can see it drop down to 94, 93%. We're kind of freaking out initially. Then you realize it's all the blood. In the next 2 cardiac circulations, then the saturation zooms up to 100%, and everything gets better. Okay? But do expect to see that if you start infusing blood too fast. This is the alveolar gas equation. You have to know that. You have to be able to know this equation so you can calculate the AA gradient. The AA gradient is a measurement of how well oxygen is transferring from the alveoli into the arterial, or basically into your radial artery. Okay? Now, how does that make a difference? Well, here's the issue. If I tell you that my PaO2 is 100, is that okay? What would be the right answer if I gave you that person is normal, that person has I just say, well, one of the answers would be that person is normal, that person is not normal. I don't have insufficient information to figure out what it is. Which was the right answer? If I told you that if somebody's PaO2 was 100 on a blood gas, what's most people's reaction when they hear it? That's why it's such a great test question. You would think it's normal, right? Most people that say, if I tell you that PaO2 is 100, that'd be good. You'd be happy with that, right? And my answer to that is you better know what the FiO2 is, and you better know what the atmospheric pressure is. Because if I was 100% FiO2, what should be my PaO2, my big A alveolar O2? It should be like 600, right? 660. So my blood gas value should be also 600. Shouldn't be 100. So the answer would be insufficient information to figure out that value. Okay, you have to have those values in place before you develop an AA gradient. Now, how does that trick you all the time? I have seen this happen to many people in clinical. They draw blood gas, and they look at the number, and the number looks normal. The normal comes back 110. And they go, yoo-hoo, the guy's oxygenating just fine. And then the next person looks at it and going like, this guy's really sick. And the student looks bewildered and says, how is he sick? His PO2 is 110. He's great, doc. He says, no. He's on 100% FiO2. He should be at 600. Okay, that means he's got 1/3 of the lung volume that he should be having ventilating. You've got a big problem in your hands. Okay, so you could be with a 60% shunt and still have a PaO2 of 100, which means your saturation would be 100 too. So you're not going to pick up on it. Okay, so you have to know what your FiO2 is and your atmospheric pressure. Okay? All right. Now, PaO2, which is arterial oxygen concentration and saturation, are related, but they're not the same thing. They're related in the sense that they're related to what's called the alveolar gas equation, which we'll get to in a minute. But they are related in that way. Now, ultimately what you're trying to do is you're trying to transfer gas via diffusion downstream. So you're going from alveolar concentration down to arterial concentration. So diffusion is dependent when we are talking about alveolar plasma. That's what we're looking at. That's why it's diffusion dependent. Okay? Measuring the AA difference to determine the health of the alveolar membrane is actually a good thing. But oxygen transfer is also perfusion dependent due to hemoglobin. Okay? So your hemoglobin drops off, you're going to have a bigger problem getting gas across. When oxygen transfers, it goes to plasma, is basically extremely inefficient. Okay? It is basically terrible. Okay? So when I look at my values, when I look at my values on my readings on my blood gas, and I say PaO2 and versus the saturation, which is a more important value? Is it saturation or PaO2? PaO2 is basically useless. Only thing PaO2 is telling me is how healthy the alveolar membrane is to get across. The way I want you to think about it is I want you to think that oxygen transfer occurs in two separate ways. There's two companies. One company is on a river. Okay? And what we're going to do is everything that is plasma, we're going to take the ducts out here, okay? And we're going to throw boxes inside their little river over here. Okay, I'm going to throw 150 boxes into that little river that's there. And then we're going to walk over to the hospital and we're going to wait for the boxes to get there. You're going to be waiting a long time. Okay? Maybe one box out of 100 might get there. Okay, so really, in essence, what I threw into the plasma is basically useless. Okay, it's really not going to get to my tissue. But where is oxygen really moving along? And the answer is we're going to put a bunch of Big Mac trucks out here. Okay, we're going to make it a Federal Express truck with an extended truck. Okay, we're not going to just make it a big truck. We're going to make it a truck and add a third of a truck onto it. So in other words, it's 1.34 to 1.39, depending on who you want to believe, times how full the truck is, how saturated it is. If I put the truck and fill it up 100%, that means it's got a lot of boxes. Okay? And then the number of trucks, which is a hemoglobin, is the number of trucks that I have. Normally I have 12 trucks that are moving around my bloodstream. Hemoglobin around 12. And that's great. But if I reduce it down to 6, that means my efficiency of box transfer is down to 50% decrease. Even though I have them filled to the brim with boxes, I start not getting enough boxes there. Once I get down to 4, I'm down to a quarter of what I should be delivering. Now the body begins to starve for oxygen. Even though the truck is full, you could be 100% saturated and you're still dying when you have a hemoglobin of 4. It all has to do with how many boxes you're transferring per time. See how that analogy should work in your head? So if I see somebody in the operating room that's bleeding to death and the saturation is 100%, I shouldn't feel good about it. Okay? I'm just losing my trucks. They're going over the side of the cliff. Okay? I need to put the trucks back in to get my load where it needs to get. Okay? So it's hemoglobin is the only efficient system. So the trucking company is what you really care about. Now, that's what we call the oxygen carrying capacity. This description of these two companies is made up by this equation called the oxygen carrying capacity. So it tells me how efficient my two companies are. Okay? So where is our values here? I'm going to make our blue here. This is going to be my plasma dissolved. So when I put 100 boxes here, okay, of that, only 0.0003 are going to get there. So if I were to put 100 boxes in, what's the chance of it getting there? 0.003 times 100. So 0.3 boxes out of 100 would get there. Woohoo! That's not significant. So that part of the equation can be chucked out the window. You don't want that company. You hire somebody like that, you should be shot. Okay? That means those guys are sitting around, you know what they're doing? They're having lunch on your dime, they're having a good time, they're going, hey, that sucker is great. I'm sitting out here just basically being like a duck. I'm sitting out there on the plasma having fun. Okay? So it's totally useless. And instead, you want to get the big company. You get the old hemoglobin company. Okay? And these guys have their Mack trucks. And so they have their trucks. But they don't have just a regular truck. They got an extended truck. So this is 1, and this is 0.39. Okay? So that's 1.39 times the number of boxes, times the number of trucks that I have. That's the hemoglobin, times the saturation, which is how full my trucks are. You see, you don't have to memorize it. You just have to understand it. Okay? To this day, I don't memorize this. I just understand it. Okay? I don't memorize equations. I hate memorizing equations. Now, that being said, this value will vary between textbooks. Americans will use the 1.39 value. Okay? If you read British literature, it'll use 1.32 to 1.34. Why the difference? Because hemoglobin is different in British blood? They might think so, but no. We might think we're richer than they are. In other words, if you give a bigger truck, if you're giving the value 1.39, that gives you a better oxygen carrying capacity. In reality, what it is the crystallography studies that were done on hemoglobins were done by the United States, and it showed that your maximum capacity, your biggest truck possible, is 1.39. But in reality, most of the trucks are not that big. Most of the trucks in reality are a little bit smaller. They're 1.32 to 1.34, depending on who you really talk to. Okay? So when you see that, don't be alarmed. Okay? That Dr. Nolan's crazy. No. Okay? I'm going to give you the 1.39 to memorize. Why? Because you're in the United States, and you're going to be tested on that value, even though it's wrong. In reality, it should be 1.34. It's really I think the more accurate value is 1.32 is the most accurate value. So if you want to go crazy and go to that value. But most of us will stick to 1.39 since we're in the United States. Okay? Does that make sense now? You shouldn't have to memorize this equation. You just understand. That's oxygen carrying capacity equation. Of which most of the time when we're looking at it, the only thing that we use in clinical is the first portion of the equation, the 1.39 times the hemoglobin times the saturation. We don't care about the PaO2. The only thing the PaO2 tells us in clinical is tells us the health of the diffusion gradient that we have. It tells us the AA gradient. So I calculate my alveolar gas equation to figure out my AA gradient. Okay? If I'm at 100% FiO2 and if I don't see a PO2 of 600 at least, I get worried. If I see a value of 100, I know I've got a big problem. Okay? If I saw the other day we actually put the patient to sleep at 100% FiO2 and the saturation was running right around 90%. And I said, well, the PO2 is going to come back 60. And sure enough, the PO2 came back 60. And we should be at 600. This person was in dire trouble. And when you listen to the patient's lungs, completely wet, complete pulmonary edema, started giving diuresis and got him back up to around 250 on the PaO2 by the time we were finished the case, it was about 2 hours later. But the guy was pretty sick. And we didn't, guess what we did at the end of the case? He stayed intubated. He bought the tube. He went to the ICU directly. Now there's two different definitions that I want to make sure you're clear on. Okay, hypoxemia is different than desaturation. People have bastardized this terminology and it really bothers me because it's not the same thing. Hypoxemia has to do with emia, which is dissolved blood. Okay, that's the plasma constant. If I tell you that you're hypoxemic, can you be desaturated? And the answer is no. Sometimes you are hypoxemic, but you're not desaturating. Hypoxemia basically is telling you that your PaO2 expected to your value is lower than expected. Okay? Sometimes you can have a PaO2, let's say, of 90, which should be a 600. That person's hypoxemic or developing hypoxemic signs. Okay? But their saturation is still 100%. So they're not desaturated. The reason that wording is usually confusing is that most of the time hypoxemia, which leads to a low PaO2, usually will also lead to a low hemoglobin concentration, right? Which then will drop saturation, which then will drop your sats. Okay? So it's not the same thing. If you see desaturation, give me an example where you see there's no hypoxemia, but there's desaturation. Anybody got one? What? Carbon monoxide poisoning. Carbon monoxide poisoning would not give you hypoxemia. That person, if the person is given 100% oxygen, the hemoglobin is bound to the carbon monoxide, so they would desaturate, even though their plasma content would be adequate. Cyanide would not do desaturation. Cyanide attacks the mitochondria. Actually, saturation rises with cyanide toxicity. Why? It doesn't have anywhere to go. You kill the diffusion gradient on the cellular side, so there's no reason for the hemoglobin to unload their oxygen. So the SpO2 rises, and then the actual hemoglobin saturation increases on the way out too. Where you pick it up is the SpO2 actually goes up with cyanide toxicity. Yes? Yeah, he's desaturated. He's desaturated and hypoxemic. He's both. Okay, because he's got low levels of oxygen, so he's hypoxemic and he's desaturated. That's what most people associate, but there's situations where you can be not hypoxemic and desaturated, and the reverse is true as well. Okay? The 4 causes of actual hypoxemia. This is what I have to go into. I'm going to go into this for 5 more minutes, and we'll stop here. I think we'll get to slide number 10. So if you have somebody and you draw blood gas and the PaO2 is low, that's what we call a hypoxemia. Okay? That's not the same thing as saturation. Please make sure that's embedded in your mind. If PaO2 values are lower than expected, then you have to say that person is hypoxemic. Even though the number appears, okay, if I tell you that PaO2 is 100, is that person hypoxemic? You don't know the answer until you know the FiO2, right? Okay? But if I tell you that that person's PaO2 is 100 and their FiO2 is at 1 at sea level, then that person's value should be 600 and something, and instead you're at 100. That person is hypoxemic. Okay, and they're not desaturated, they're still 100% saturated. Okay, so it's different. So hypoxemia means how much oxygen is expected in the plasma to the expected values that you should have. If you're below the value of the AA gradient, now you're developing hypoxemia. Now there's 4 causes of hypoxemia. 3 of them are highly responsive to oxygen therapy, and 1 is not. Okay? The 3 that are responsive to oxygen therapy are hypoventilation, okay, diffusion limitation, and VQ mismatch. And the one that's more resistant to oxygen therapy is shunt. Now, what's the definition of hypoventilation? Hypoventilation means that you're not getting enough gas down to the alveoli. The most common cause of hypoventilation, it tends to occur with impairment of the central nervous system. Okay? If you're drunk, if you're out partying too much and take a few ingestions of drugs that you shouldn't be doing, like narcotics or something like that, you come into the anesthesia and be put to sleep with narcotics, you're going to hyperventilate. Okay? You give an induction agent to somebody, they're going to hyperventilate. So the most common thing that we see in the operating room is hyperventilation. Okay? In reality, what do you see? What's the most common clinical cause of hypoxemia? It's VQ mismatch. It's the 4th one. Okay? Because of pneumonias and things like that. So clinically, what you see is VQ mismatch. But in reality, in the OR, the most common cause of hypoxemia is hypoventilation in us. Okay? What you see with this is that you get a decrease in the alveolar oxygen concentration. This ends up causing a decrease in the arterial oxygen concentration unless you will increase FiO2s. So you can actually mask hypoventilation very easily with giving higher and higher levels of actual oxygen. What you're not going to be able to hide is the CO2. What will happen is you hyperventilate, the alveolar CO2 content's going up, but because your dead space ratio to ventilation ratio, your end-tidal CO2 is falling in that situation, so you think everything's okay, but in reality it's not. Okay, so that individual keeps accruing CO2 in the bloodstream. Okay, so make sure you understand the difference. Okay, CO2 in the alveoli is going to mimic what's going on in the blood vessels, so it's going up. Okay, but the dead space CO2 is falling because you're not really effectively ventilating alveoli. So when you measure end-tidal CO2, you'll see a drop in end-tidal CO2. Okay? Now, you're still ventilating effectively to a certain degree, you'll see the CO2 actually will rise. But what I'm talking about is severe hyperventilation to the point where you're really just moving dead space gas, and then CO2 actually falls on your end-tidal CO2 portion. Okay? That's kind of a hard question. You'll see that people answer it to it differently. You have to sort of slow down and ask the question, how severe is the hyperventilation? If they tell you, well, it's very severe, then end-tidal CO2 is going to fall. If it's so-so, we got 50-50 mix still, then the answer is you're going to see the CO2 actually elevate in that situation. But as you get into worsening, then it drops off on you all of a sudden on the end-tidal CO2.